I would like to introduce our next speaker, who is going to talk to us about colorectal cancer screening in the community. Let's welcome Dr. Joseph Ravenell, who is an associate professor in the departments of population health and medicine, and he is also the director of diversity in research here at Perlmutter Cancer Center. Let's welcome Dr. Ravenell.
Good afternoon, everyone. It's a pleasure to speak to you today. Thank you so much for taking time out of your day to come. March is one of my favorite months. It's my birthday month, but it's also a month that we get to talk about colorectal cancer, which is a cancer that we know is preventable with timely screening. Unfortunately, there are inequalities in the rate at which different populations are screened, and there's a whole list of reasons for that, but we're going to talk about some of our efforts here at NYU to essentially address some of the disparities that we see in colorectal cancer screening. So you guys have probably seen something like this slide a couple times today, but it shows that basically when you compare the death rate from colon cancer in black men compared to that in white men, that black men are significantly more likely to die from colorectal cancer. In fact, black men have the highest death rate from colorectal cancer compared to all the other groups in the US. And we believe that's due mostly to lack of timely screening. We can talk a lot about some of the reasons for that. One of the major ones is access to screening. And by access, I also talk about insurance coverage. Often to get screened for colon cancer, it's not cheap. And so if insurance coverage is an issue, then screening is going to be a challenge. But what we found through some of our research is that one of the big barriers is knowledge, and people knowing, and black men in particular, knowing that they have an elevated risk of dying from colorectal cancer. So many of our efforts focus on educating black men about the special implications for colorectal cancer for them. So when we look at colorectal cancer screening, we start here for men who are eligible to be screened for colorectal cancer. And while there are kind of shifting guidelines about who should be screened, the United States Preventive Services Task Force recommends that everyone who is of average risk be screened at age 50 and older. The American Cancer Society recently came out with guidelines that actually suggest that everyone who's of average risk be screened at age 45. But even when someone is of screening age, there are several steps to actually successfully getting screened. So first, the person has to be connected with the healthcare system, and there can be barriers here to men even seeking care. Then once they're in the healthcare system, the provider or the doctor actually has to make the recommendation. Believe it or not, there was a time when not all physicians recommended colon cancer screening for people who were of age. And once that problem came to light, we did a much better job of ensuring that we let our patients know about the need for screening. But even once the recommendation is made, once the colonoscopy or other screening modality, once the referral for screening is made, then there's a matter of making the appointment, of completing the prep. If you choose to do something other than colonoscopy, having access to those tests. So not only getting those, but then correctly completing those tests. All those are really important steps that have to be done correctly in order for a good screening test to be done. And one really important point is, if you're doing a screening test other than colonoscopy, if that test is abnormal, you have not been screened until you actually complete the follow-up colonoscopy for that abnormal test. And so if you're using a FIT test or some other kind of stool card, if those tests are abnormal, then you have to follow it up with a colonoscopy. And we believe that screening is not complete until you actually do that follow-up. So it's not an easy process by any means, getting screened for colorectal cancer, but there are definitely steps along the way where we can try to target how we can improve the adherence to this process. So one of the major contributors to lack of timely screening among Black men, as I mentioned, is access. This is data from when I was in Dallas, Texas. This was a population-based study of over 6,000 people, and what we learned is that Black men are less likely to have a primary care doctor, again, for a whole host of reasons, but that can be an extremely important barrier to getting referred for colon cancer screening. So we started to think, if we're not having success reaching Black men in clinical settings, what are other ways that we can reach them? And so the Barbershop is a place where I started doing work about 15 years ago, drawing on my own experience growing up and going to the barbershop with my father and realizing how important a part it was in terms of being a part of my life. It's a place where men go for friendship. It's a safe space where you can talk among your colleagues, talk with your barber about just about anything. And healthcare is often a big topic of conversation in the barbershop. And we showed in Dallas that if we can have barbers talk about high blood pressure and actually measure blood pressure or encourage men to get their blood pressure measured and treated, that it was a very successful way of getting men to take care of this very important condition. So when I started here in New York City, the thought was, well, if the barbershop was a good place to talk about hypertension, high blood pressure, it might also be a good place to talk about cancer screening, and in particular, a cancer that has special significance for Black men because they have the highest death rates from it. So why barbershops? It's often affectionately known as the Black Man's Country Club. It's a relaxed, non-medical atmosphere where men can spend lots of time. It's a place where some men go as often as once a week. The barbers are well-respected members of the community often. And here in New York City and in other states as well, barbers actually have to go to barber school to be licensed, and you have to be actually licensed in order to be a barber here in New York State. And part of their training in school includes a component of healthcare. And so the idea of promoting health and talking about health is not a foreign concept in the barbershop. And I've heard many men say that they trust their barber more than they trust their doctor. And if you think about that, it's not outside of the realm of possibility. If you're going and establishing a rapport and a relationship, once a week or twice a month, every year for 7 years, which we believe is the average that Black men have been with their current barbers, that you build a much more intense and trusting relationship with the barber than you do with a doctor who you may see 2 or 3 times a year. So we asked the question, when we think about the problem of high mortality rates from colorectal cancer, yet lower screening rates, can we identify unscreened men in the barbershop and essentially navigate them to where they can be screened for colorectal cancer? So we we replaced the doctor's office here with the barbershop, with the idea that basically a patient navigator can actually act in this space to actually help to escort or navigate men into the healthcare system to ensure that they get the care that they need. So we started the NYU Men's Health Initiative almost nine years ago, and we were very fortunate to get funding from the National Institutes of Health to actually do a series of projects. One was based in barbershops, one was based in churches, and excuse me, basically what we did was we went to barbershops, identified men who were unscreened for colorectal cancer, and they were randomized either to be connected to a patient navigator or to receive usual care, which was just printed information about where they could go for colon cancer screening. And we followed them for 6 months and looked at the end of it to see which group of men had a higher screening rate. So the patient navigation intervention that we did, it was typically multiple sessions. For the first session, the patient navigator, who was, we worked with several over the duration of the study, and the patient navigators were people that we hired from the communities that we were working in. We were working primarily in northern Manhattan and Brooklyn, and so we were sure to hire patient navigators from those parts of the city. So the first session was an introductory session where often what we did was just acquaint men with their risk of colorectal cancer and to let them know that they had a higher risk of dying from colorectal cancer than any other group. And then in that first session, we also tried to figure out what were the barriers to men getting screened. There were at least 2 or 3 other sessions that followed that over the 6-month period, where the navigator would revisit barriers, but really would focus on what are the things we need to do to make sure that this man gets screened in a timely way. So we were very fortunate to work with over 200 community partners all throughout the city in all 5 boroughs. We focused primarily on barbershops, but we also were doing work in churches, several social service organizations, mosques, and other community-based venues. So this is some data from the men that we encountered in the barbershop. On average, they were 55 years of age, which is just the age that we wanted, although ideally we would focus even younger and try to get men to get screened even closer to the age of 50. The majority were born in the US, the majority spoke English at home. Only 25% were married or living with a partner, and that's important because we know that a big part of the success of people getting screened has to do with who is in their corner, encouraging them to go get screened and helping them, with whatever they need in order to get screened. And so sometimes not having a partner can be part of the barrier. So it was important for us to note that. This was closer to 2008 to 2009 when we first started the study, and so there were huge economic challenges in our country, but I think the men that we were working with were really impacted by that. And as you can see, household income of $17,000 a year. A very high smoking prevalence we also found, and it's something that we are looking at how to address as well. So along the way, we tried to assess what some of the barriers to screening were, and by far the biggest barriers were lack of knowledge about colorectal cancer as well as colorectal cancer screening, and then risk perception, basically men not believing that they were at risk for colorectal cancer. When we looked at the major facilitator of screening, as reported to us by the men who participated in our study, if they prioritized prevention or thought that was important, that was a big facilitator of them deciding to get screened. So after 5 years of this study, we basically saw that the men who were connected to patient navigators in the barbershop were about twice as likely to get screened for colorectal cancer compared to people who just received a referral from their doctor. So this was a hugely successful study for us, where we essentially, doubled the rate of colon cancer screening with the intervention of putting patient navigators in the barbershops. Now, we still have a ways to go because, as you know, the national target for screening rate is closer to 80%. But when you consider that all these men at the beginning of the study were not screened, we were happy with the success that we had. But we're working now to see how we can improve this number closer to the national targets. I think it's also important to note that when you look at the literature on patient navigation, the literature often focuses on navigating men from the primary care doctor's office to the colon cancer screening test. We were talking about navigating people from the community to the screening test. And so when you consider that many of the men that we encountered didn't even have primary care doctors, we were happy that we were able to connect to many of these men. So the take-home results from our study are that participants who received the patient navigation intervention, where they met with the patient navigator in the barbershop, they were twice as likely to get screened compared to those who just had a usual referral from their doctor. And when we looked at whether or not insurance played a part in how effective our intervention was, we found that even when we controlled statistically for insurance and for health literacy, the intervention still remained effective. And so what that means is, regardless of whether you had insurance or regardless of what your level of health literacy was, we still had success in navigating people to successful screening. We worked with an incredible group of navigators and community members. We actually asked our navigators kind of what were the strategies they used for reaching over 700 men in the barbershops. Kind of interpersonally gifted navigators, identifying the right neighborhoods, going to where the highest needs are, to those neighborhoods where you're more likely to find people who have not been screened, and that sometimes takes some work. Actually on foot, traversing different neighborhoods and finding where the right places to be are. And then persistence, right? Not just, when you encounter someone who hasn't been screened but who needs to be screened, kind of not just taking no for an answer, but continuing to educate them and to encourage them to complete this life-saving screening. So we're very happy to have been part of the movement in New York City, where essentially the disparities in screening have largely been equalized over the last 10 years or so. And when you look back in 2003, where there was a significant difference between the screening rates of black men and white men, by the year 2013, which was right when we were doing our work, you could see that the rates had equalized. So we definitely take some ownership of being part of that. And then here is how New York City fared in terms of increasing their screening rate to almost 70% over that time period. And importantly, the mortality from colorectal cancer actually decreased for all groups over the early part of the 2000s, when this work was happening. So this work has led to other patient navigation programs. We now have a cancer prevention navigation program here at NYU that includes both navigation for colorectal cancer screening, but also for breast cancer screening as well. And we've just embarked on projects that focus on navigating community members for screening for other cancers as well. So this work in colorectal cancer has been very important for our approach here at NYU for reaching the community and helping them to complete screening. We also, here at NYU, we have a very active Department of Population Health, where we actually look at how we can help a multitude of communities. And one of my colleagues, Dr. Nadia Islam, she actually does work in the Asian community, and so she recently published some work looking at data from 2013 to 2016, looking at people who are eligible for colon cancer screening, and basically found, and this is data that comes from the New York City Department of Health, found that South Asians in New York City are significantly less likely to have had colon cancer screening over this time period compared to other groups. So Dr. Islam and her team are really working hard to find approaches to really reach out to this community to really try to equalize the disparity that we see. So thank you so much for your time, and just want to acknowledge some incredible team members who worked with me over the years, and also acknowledge folks here at NYU, the funding agencies, the Perlmutter Cancer Center, of course, and people in my academic department here. So thank you very much, and I'm happy to take any questions.